Hello, everyone. Welcome back to Hot Seat. I'm Omid Moghaddas, joining you from Tehran. And once again, I'm so grateful to have the chance to be with you all from this educational platform, especially nowadays that we have limitations for traveling and joining great speakers from around the world. So it's a good opportunity for all of us to get together and gather together through the virtual format and learn from the best in the field of periodontology, prosthodontics, and implant dentistry. And today I'm super excited again to have a very dear friend and master clinician and one of the super skilled surgeons and prosthodontists in the world today. Dr. Bach Lee is here with us from United States. Hello, Bach, and welcome to Hot Seat, my friend, and thank you for the invitation and accepting the invitation, I have to say.
Thank you. Really an honor for me to join you. I'm so excited to be able to be a part of a great program that you've put together. And as I said earlier to you, as we were talking, I really want to congratulate you for what you're doing in spearheading, bringing together this forum of really wonderful education for all the folks out there who are in this time at home and not able to attend meetings live. I've been able to listen to some of the meetings, some of the lectures that you have put together, and so really a great job you're doing. And so congratulations to you, Omid.
Thank you, my friend. Thank you so much for joining. And today, for all the people watching right now, we have a very, very interesting topic to talk about and to discuss. And this is one of the high demand topics in the field of implant dentistry, and that's the retreatment of aesthetic failures. Something that we know that by sticking to the principles, we can be able to at least prevent them, but knowing the strategies and treatment options for how to manage the complications or how to control the complications is definitely a must to know. And who can be better than Bach to talk about this topic? So we are all super excited. And as a tradition, before we start the presentation, I would like to have Dr. Bach Lee's CV for all of you. And then we'll straightly go to the presentation. And at the end, we will have a discussion on the topic. Dr. Bach Lee completed his specialty training in oral and maxillofacial surgery at Oregon Health Sciences University and is currently clinical associate professor at the Herman Ostrow School of Dentistry at University of Southern California. Dr. Lee has authored over 14 chapters in textbooks on bone regeneration and dental implants and has published extensively in peer-reviewed journals. He has been an invited speaker in so many prestigious events and organizations like American Academy of Oral Maxillofacial Surgeons, Academy of Osseointegration, Prosthodontics, American Academy of Aesthetic Dentistry, American Academy of Implant Dentistry, College of Prosthodontics, Greater New York meeting, and all these big meetings. He was one of the speakers all the time. Dr. Lee was inducted as an honorary member of the American College of Prosthodontists and is a recipient of the Charles E. English Award in Clinical Science. He is a diplomate of the American Association of Oral Maxillofacial Surgeons and holds fellowship in the American College of Dentists, International College of Dentists, and the International Associations of Oral Maxillofacial Surgeons. Once again, it gives me a true pleasure to welcome you, my friend, and we are ready for your beautiful presentation. The platform is all yours.
Thank you so much. So I'm going to go ahead and share our screen here. So, you know, the topic that I want to discuss today, which is the topic of retreatment of aesthetic failure. We often call these the ailing implants, or the implants that have aesthetic issues, tissue recession, bone loss, and focusing mainly on the aesthetic zone. This is a very relevant topic in just about any to any practicing implantologists for the fact that as you know, Omid, when we look in patient's mouth, we see this as a very, very common scenario, a case such as this. And so I'd like to talk about some of the etiologies of why we see this, and then we will discuss how to manage these problems. These are extremely challenging problems to fix. And as you know, when we have a problem and we go in and we remove implants and then we augment and then we retreat these cases, how challenging they are to retreat them to make them look somewhat normal again. So that's going to be the format. So we'll talk about why we get these problems, how we can prevent them, and then we'll talk about treatment and retreatment. So so essentially, the topic really hasn't been discussed until maybe about the last 10 to 20 years. And the first term that I saw on the ailing implant was actually described in the Journal of Clinical, or the Journal of Periodontology in 2000. So this is about maybe 20 years ago. This was the first use of this term. And the term was used, it was introduced, and it was defined as problems that were limited to the soft tissue surrounding implants and not involving the supporting bone. And so I found that that was an interesting definition because it is essentially separating the two issues, that two problems can exist and yet not involve the supporting bone, as if they were two separate entities. And so I believe that this was what our understanding was when we first were focusing on implant problems. And so I believe that these two problems are very, very closely interrelated. And in fact, most of the problems that we see in implantology are rarely black and white, and that most of the problems have etiologies that are very, very intertwined. And this is what makes implantology so difficult. It is not a black and white, and medicine is not black and white. We live in a very gray and very colorful world. So that's what I would like to focus on this topic with etiology. Now, we know implants integrate in with high success rate. We can take teeth out, place implants, and most of the reported survival rates after 1 year is in the high 90s, from 97 to 99%. And so if you look at most studies, implant integration is extremely high, which speaks to the power of integration, of osseointegration. So integration is easy, and it's not a problem. However, the problems that we see with the tissue stability, as you know, and as most folks know, is that it is not often stable around implants. So these were implants that I placed. Now, I started my implant career close to about 20, close to 30 years now. So it's been 3 decades when I started dental school, exactly 30 years ago. And so about 20 something years ago, I placed these implants here on a patient. And this was when it was restored. And yet about 4 to 5 years later, when I saw the patient, I was extremely surprised to see, this migration and loss of tissue. This was a very young patient. He was about 22, 23 years old. And so when I placed it and restored it back then, I thought, okay, I was happy with it. And so it was a very difficult challenge. And I looked at this and I thought, well, how do I fix this problem? You've got very thin, you have loss of keratinized tissue, you have significant recession exposing the restorative work and the implant platform. And so when I looked at studies on this back in 2002, when it was first reported, back 20, 30 years ago, we were happy if the implants integrated. So back then, there were very few studies that looked at this problem. And one of the few ones was by Thomas Oates in 2002. And at that time, he reported that up to 61% of patients, if you follow them over time, long term, you'll see about 1 to 2 millimeters of facial recession. Now, this is a high number. This is, again, back in 2003. Another study, more recently, 2011, by Reyes, the group out of Belgium, when they looked at implants that were placed in, and this was done by experienced clinicians who go to Bruin's group. And this is a small study, but it was a study comparing immediate implants versus conventional implants. And what they did was they extracted a tooth and placed an implant. And then they followed these implants, and they looked at the white aesthetic score and the pink aesthetic score. And what they found that was interesting is not so, the implant's all integrated. What was interesting is that when they looked at the aesthetic score, the pink aesthetic score out of 14, that 24% of the cases had a pink aesthetic score of less than 8. Now, essentially, that's an aesthetic failure, as you know. 24% means that 1 in 4 of these cases that were done, was reported, done by experts, essentially by 2 master clinicians, reporting an aesthetic failure of 24% of 1 in 4 cases. Now, as you know, in private practice, if you place an implant and you have 1 to 4 cases that come back that have the potential to have this problem, that is a very, very challenging problem. Now, 70%, 68% were acceptable, and that very few were actually perfect. So this is a common problem, and it is also not just a common problem, it is a problem that can pose potentially catastrophic failure for our patients, because as we play, after the implants are placed and they're integrated, they're very challenging to correct. So why is it so hard? The discussion that, as I told you back in the beginning, is that we don't live in a black and white world, and that we live in a very, very intertwined, that etiologies are not, there's not one common cause. That the problem often comes down to multiple problems, and I've isolated, or I've listed 3 things that, of course, we must break down these failures to. And we know these 3 things, that, bone is important around implants. Of course, we know soft tissue is important around implants. And of course, implant position. These are the 3 primary things that are extremely important. And we all know that. We all know that. The issue is that, as we said in the beginning, these do not exist by themselves. It is a balancing of these 3 things that makes implant challenging. Anybody can, as you can see from implant integration, if you place an implant, after 1 year, 97, 98% will still be there. So integration is not a problem, but it is balancing this that is a challenge. The analogy that I often use is, I love this sculptor. This was a sculptor that was done by a sculptor by the name of Richard McDonald. If you go to Las Vegas in the Bellagio, this is a sculpture that is one of the pieces that is shown. Now, if you look at the sculpture, this is a sculpture of a man who's blindfolded, and he's balancing himself on a cube, on his tippy toe. And on this cube is being balanced on a point. And in his 3 limbs are little balls. As you can see, these little balls. And so the name of this sculpture is Blind Faith. And the meaning, and of course, everybody has a different perspective and the definition of what they define for this. But what I take away from this is that life is full of balance, and that in this particular sculpture, this person is balancing himself with these 3 balls. Now, this could be in life, it could be, for example, one of the balls could be your career. One could be your family. One could be your health, or one could be your spiritual life. And if we lose balance, if we focus too much maybe on our career, we may fall off this little cube. And so if we disrupt this balance between bone, soft tissue, and implant positioning, this can cause to a failing implant, or an ailing implant, or an aesthetic implant failure. And this is why I always say implant dentistry is so easy that essentially the majority of clinicians around the world, everybody is placing implants. However, but yet in expert hands, you still have 24% that report complete failure. that they can't control it. And it's because this balancing act is extremely difficult. It's not just getting the bone and getting the soft tissue and the position correctly. It is balancing them together in the right balance that creates an ideal result. So what do I mean by how do you balance these three things? Well, let's talk first about bone. Well, we know that bone exists, in 3 dimension, and that, we have to have good bone thickness. We talk about how we want about 2 millimeters of thickness, but that thickness has to be at the right buccal bone crest. So if you have thickness, but it's in the wrong crest, you have a long tooth. You have to have proximal bone height that is healthy. You have to have good bone quality. But in all of these 3 dimensions, the most important aspect is the buccal bone crest. In all bone augmentation techniques, or in all implant procedures, the goal is to achieve a normal buccal bone crest. If you cannot maintain a normal buccal bone crest, you will have essentially an aesthetic failure. So John Coyce described 3 types of crest. There's the normal crest, where the buccal crest is 3 millimeters away from the gingival margin. And then, of course, there's the high crest, which is when we have too much bone. There's a lot of bone. These are patients that have exostosis, thick bone, and high crest. These are a luxury to work with because they have a lot of bone. And then there's the low crest, patients that have bone that is low according to where their gingival margin is. Of course, these are the high-risk patients. In all of our procedures, we want to have ideally a normal crest around our implants, which is 3 millimeters away from the gingival margin. This is what we call the biologic width. Now, if we're going to augment, you're going to want a high crest. Why? Because every augmentation procedure undergoes a remodeling process, undergoes resorption. So there's not a procedure, a grafting, or regeneration procedure that doesn't undergo this. Even soft tissue undergoes this. Even if you have a scar, go undergo a type of remodeling, collagen reorganization, and shrinkage. So bone, when we augment, we should always try to augment, overcorrect to a high crest, but it essentially remodels to a normal crest. Can't overemphasize that, and we'll talk about that a little bit more when we talk about retreatment. So bone thickness has to be in the right crest. So all too often we see this as a common mistake among practitioners that are especially in the beginning phase of their career. When they extract a tooth, they see there's a low crest, as you can see in the preoperative picture where the tooth is, and the implant is placed at the crest. What essentially happens is that ends up being too deep, and now you have a tooth that has lost the gingival margin height, and so now you have a long tooth. Very difficult problem to fix. So you see that this is a violation of the implant position based on the crest. So whenever we have a low crest, the first thing you want to do is you have to correct the buccal crest. All of grafting procedure is to correct and stabilize the buccal crest. It doesn't matter how much of a vertical defect you have, or how terrible a palatal defect. All augmentation should be to stabilize the buccal crest, not just graft it, but to stabilize it. So, if we were to extract the tooth, so here is an example of a patient, a young girl. She's 22 years old. She's undergoing orthodontics to straighten, correct her alignment. But she has a tooth that's had an apicoectomy here, and we're going to extract this tooth as part of the treatment. And so you can see from this here that she has a large periapical radiolucency here. And on the CT scan, you see that she's had an apicoectomy. And so the buccal crest here, and you can also see that the soft tissue around this tooth is very, very thin. And you may not be able to see it on your computer, but the soft tissue thickness is about 1.2 millimeters. So it's a thin soft tissue, low buccal crest, and thin buccal crest. And so upon flat reflection, you can see that this crest, although it exists and it's in the normal, somewhat normal position, it is an unstable crest, and that just the extraction of the tooth will cause collapse or resorption of this, resulting in a long tooth. So we have to correct this. And so the way we correct this is, I want to correct this to a normal or a high crest. And so my strategy in doing this is that I make an incision, and this is an incision design that I like to use, which is a site-specific vertical incision and an itunnel subperiosteal on one side. And this type of incision, I call the open book flap, allows me to essentially make a normal crest into a high crest by localizing the graft material and preventing migration. Now, many people may look at this and say, you know, you're violating surgical principles by placing a vertical incision right at the site of your augmentation. Most people will say you must, when you make a vertical, they advocate a vertical incision distant to the grafted site. And so, of course, I agree that that is also has advantages, but as we said, medicine is not black and white. You know, we live in a gray world. There are advantages and disadvantages to everything. And so by making a site-specific vertical incision and doing only a subperiosteal on the other side, I'm able to advance the soft tissue very easily at the local site to create gingival margin and to keep my graft from migrating. So essentially keeping the graft there. So I basically overcorrect in anticipation of this resorption. Then I suture it, and I don't go crazy with trying to get primary closure. I just leave a site this. And what you see over time is that over time, after 4 months, you see this. How did this happen? Where essentially we started where the tissue was high, the gingival margin was equal to the adjacent tooth, but yet at 4 months, I have too much tissue or too much bone, essentially. I've created what I call the high crest. Now, this is an easy problem. This is a problem we want to have because our normal problem with implants is that the tissue goes apical. So we want to buy insurance. And so this is how my way to create this insurance. And it's done by using this type of incision, this site-specific vertical, again, the in-book incision. We've been using this now for about close to 2 decades. So we have too much bone, and by leaving the area slightly exposed to heal, we've gained more keratinized tissue across here. This is free soft tissue. You can see the before and after. We were able to correct the buccal crest because we kept the bone, the incision, keeping the bone localized. We can place the implant flapless, and most of the implants that we place after this type of procedure is done flapless. I would say about 80 to 85%. Placed flapless, still too much tissue compared to the adjacent site, the high crest. And then from here, this is a problem that's very easy. You can have too much tissue, very easy to fix. As you know, we just use provisionals to essentially manipulate the soft tissue to by adding flowable composite and developing the labial emergence profile to push the soft tissue, displace it apically. And this was restored by my prosthodontic colleague, Dr. Gianmarco O'Brien, and the restored work by Naoki Hayashi. And you can see the before and after. Essentially, we were able to control the tissue margin. So the point that I want to make here is this. If I were to have receded this too much, in 5 years, if this patient came back and there was uneven tissue margin, I can always unscrew this restoration, reduce the profile, and allow the tissue to drop back down. Essentially, that's our insurance, is that we controlled it. We had a high crest. We controlled it with our restorative emergence profile. If we needed to, in years later, 5 years, 10 years later, we can always reduce it and allow the tissue to collapse back down. So essentially, this is our plan. As you can see this, what I mean is now, when you look at the relationship between bone and soft tissue, I want you to draw your attention to see at the tissue thickness around this implant now. Before it was 1 millimeters. Now the soft tissue is 3.5 millimeters thick. How did that happen? There was no connective tissue graft done. There was no adjunctive procedure done to thicken the soft tissue, but yet postoperatively, this tissue is 2 millimeters thicker than when I started. Essentially, I want to come back to this principle and talk about this balancing act between bone, soft tissue, and implant position, and how it affects this control. So you can see that if, let's say in 5 years, if the patient comes back and somehow maybe this tooth had migrated and now we have uneven gingival margin, I can always unscrew this, reduce the margin, allow the tissue to come back down. So I can control it myself rather than let human nature control it. Now, there are many situations where so essentially this buccal bone is extremely important, the high crest. Now, there are many situations where you don't have the high crest. And of course, I would say that over 50% of the implants that are reported in the mouth do not have buccal bone. But according to a study out of Luke, what they did was they took CT scans of implants of folks that have implants in the university over a 10-year period. And what they found was that over 50% of those implants did not have buccal bone. In other words, the buccal bone had dehisced. And so we see this often. This is my patient. You can, and if you take CT scans of patients, you will see the same problem, that you take it, it looks okay, it looks like, but yet you take a CT scan and there's no buccal bone. So in this case, if we don't have the bone, we better pray we have tissue. So this is where you start to see the balancing act. If one of our little cubes, one of our little ball is a little bit underweighted, then we have to counterweight with something else, with the other ball. So this is a very important concept in that we balance with the soft tissue. So here's the situations where we have an implant that has no bone, a complete dehisce, but yet you can't see the black darkness of the metal. Why? Because the soft tissue is thick. And we know that soft tissue thickness, 2 millimeters, has the ability to hide restorative or components and metal. Joe Kahn famously uses the perio probe, a metal probe, to see if, essentially what he says is that if you can see the probe through the tissue, then the tissue is thin. Well, we know now that that number of how thick that tissue is usually about 2 millimeters. Here's a case where a patient has 2 implants. On this side, you can see the tissue is very thin. It's about 1.2 millimeters based on measured on a CT scan. And on this side, the tissue is 2.2 millimeters. So here is thick, here is thin. You can see the darkness. You cannot see the darkness on this side. So today we know now that that number has to be about 2 millimeters. That tissue greater than 2 millimeters will hide anything. You can have black underneath there, and it typically doesn't show up. But ideally, they say that a minimum of 2, but ideally 3 would be ideal. So thickness of soft tissue, according to these 3 studies, should be greater than 2 millimeters to hide the prosthetic or component, or to hide the implant dehiscence. So here's another example. Again, 2 implants at 2 lateral, congenitally missing lateral incisors are very common and a great way to learn about kind of a split mouth situation. On one implant, you have no bone, completely dehisced. On the other, you have plenty of bone, but yet they look identical. You cannot tell the difference between the 2. The only difference here is because the tissue is thick. The tissue is 2.5 millimeters across here. So it's able to hide the dehiscence of the implant. But the problem in this case is that after about 8 years, this patient developed periimplantitis on this side. And because, of course, if you have an implant that's covered with bone, an implant that isn't covered with bone, the skin that essentially could develop biofilm around the implant, because now we're dealing with rough surface. This one developed periimplantitis. And so I'd rather, in both situations, I would rather have this. A lot of times when there's thin or when there's dehiscence and exposed of rough surface, I see a lot of soft tissue graft being placed over this, which can be an acceptable treatment for aesthetic, but sometimes could be a potential problem in that it can cause a biofilm. So the problem with the balancing is that when you have both thin tissue and thin bone is when you have the combination of problem. So here we have thin tissue and no bone, leads to essentially a serious problem. So in this balancing act, buccal bone crest is extremely important. And it leads us to the issue of the tissue in terms of the balance. And now most of, as you know, the tissue is extremely important. As I alluded earlier, we want thick tissue. Tissue that is thin often recedes. Tissue that is thick has less recession. And plenty of and the thickness that we want, ideally, especially around our implants, is at least 2 millimeters, preferably 3 millimeters for aesthetics in terms of high, and of course also for to counter against recession. Thick tissue recedes less. Of course, we also know that thick tissue does better in most types of surgery. Immediate implants, crown lengthening, root coverage, GTR. Thick is better than thin. Immediate implants, same situation. When you have recession, in the 10% that's reported in the systematic review by Kosin, it is essentially most of those were thin tissue. So thick is always better than thin when you're talking about soft tissue. Of course, the landmark study by Berlin that also shows that tissue is protective of the bone, of the crestal bone around the implant. This study, Berglund in 1996 on dogs found that when he thinned the soft tissue around the implant, it resulted in crestal bone loss. Essentially, the body is creating the bone loss to create more fibrous tissue, to thicken the soft tissue. The body loves to have at least 3 millimeters, 2.5 to 3 millimeters of tissue around a foreign body. Essentially, the implant is a foreign body. And so the analogy I always use is if I walk barefooted, the skin underneath my foot is going to thicken. Or if I smoke, the sinus epithelium is going to thicken. The body needs to have a biologic barrier. So Tom Linkevicius reported this also, and I see that he's, in this study in humans. Essentially, what Berglund reported in human study, what he found is when tissue is greater than 2.5 or at about 3 millimeters, there was very little crestal bone loss. But yet when it's thin, the bone loss significantly rises. So thick tissue is important. Now, what we found is that there's a strong correlation between bone thickness and soft tissue thickness in anterior aesthetic implants. So what we did is we took patients that had 2 implants in the anterior maxilla. So they were 2 central, 2 lateral. We took CT scans and measured the soft tissue. And what we did is we measured the bone thickness at the crest, and we measure the soft tissue thickness. And what we found is that there's a direct correlation between bone thickness and soft tissue thickness of implants in the anterior aesthetic zone. So in other words, remember that first case I showed you where we tried to get the high crest? Well, how is it that we were able to get the tissue thicker? Well, by building the bone thickness. So what we found is that labial bone thickness, that as the labial bone thickens, so does the soft tissue around anterior implants. Now, mind you, this is not around posterior implants. This is what we find in the anterior aesthetic zone, that there's a direct correlation. So this leads me to the third problem. So bone is important. We need to have a high crest or a normal crest. And if we don't, we better pray we have tissue, thick, soft tissue. This leads to the third balancing, and that's implant position. Now we know the implant position it's critical. However, what I think most of us take for granted is that it is extremely critical. Implant position, even a small deviation, minor deviations in angulation, minor deviations in position, and minor deviations in depth can affect your bone and your soft tissue. In other words, these are all interconnected. That position of implant. So let me illustrate to you what I mean. So we did a study looking at the influence of implant angulation. And so this was one of the first studies to look at the correlation between implant position angulation and soft tissue thickness. So we took a patients that had 2 implants in the anterior maxilla. So 32 patients that had 64 implants, and we look at the angulation of the implants. So how do we define the angulation? We define them based on where their screw hole exited the implant. So when the provisionals were placed, they were either cingulum angulation, labial, towards the labial, or they were directly through the incisal. It's a very straight, or a very clear definition based on the screw hole access. Then we measured the soft tissue thickness around those particular implants. So in these patients, so this is how we define it. It was directly to the cingulum, through the incisal edge, or if the screw hole went out the buccal. Then we measure the soft tissue, and what we found is this, is that when the access hole goes through the cingulum, the tissue was about 3 millimeters thick. But yet when it went to the labial, in the same patient, the correlation was almost half. The tissue thickness was almost half of that when it went through the cingulum. In other words, the numbers decreased as the implants were angulated more towards the labial in the same patient. So this is very interesting because how, you know, that soft tissue can be affected by just the minor deviations in angulations in the same patient. So our conclusion is this, is that labial angulation has a high risk of soft tissue complications and crestal bone thickness is less than 2 millimeters. And another study that we did, this was an animal preclinical study. And this, what we did here in this study is we placed implants in immediate implants. We took implants out and we placed them into different positions in the ridge. Now, most that looked at immediate implants placed them right in the center. What we did was what we placed in the center, and then we placed in groups in the close to the buccal, and in other groups we placed towards the palate. And the way we defined the position was based on the gap distance. So these were 3 millimeter implants. And so one group had a gap of 1 millimeter, one group had a gap of 2 millimeters, and another group had a gap of 3 millimeters. So you can see essentially center, 2 buccal or 2 palatal. And then we went and we measured how much bone developed around the implant, but also how much soft tissue developed around the implant. So what we found was interesting is that obviously we know today that if you place the implant with very little gap, you will have very little bone. And when you place it with away from the buccal crest, you have much thicker bone. This we know. But what we didn't know back then was that it also affects the soft tissue thickness, that those that were placed further away from the gap had increased thickness versus those that were placed too close to the buccal crest. So you can start to see this balancing act of what I'm talking about. That position from angulation to placement positioning can affect not only bone, but also soft tissue. And this was in the preclinical animal studies of 48 implants that were randomly assigned to 6 groups of dogs. So, of course, we're not placing implants in dogs and cats, we place them in humans. And so I want to come back now to this congenitally missing lateral incisor, because we see this a lot. And again, as I said earlier, when we look at patients that have 2 implants, we learn a lot because we can see deviations in these 2 sides. And I've learned a lot myself by just observing patients that have 2 implants. And so this is a young gal that was referred to me by my friend, Dr. Abdi Sameni. And the patient is about 22 years old, and you can see she's congenitally missing 2 lateral incisors. She has a concavity or horizontal bone atrophy. Tissue you can see is relatively thin. And so what we're going to do is and this is there are CT scan. You can see that the ridge is atrophic, as typically what you see. So this is our implant simulation. You can see it would lead to dehiscence. So we decide that we were going to go ahead and graft. And so we do an augmentation first. This is the same incision design that I advocated earlier in the previous case, the open book incision. This is an allograft, mineralized graft with a collagen membrane. And we correct this issue. And you can see that this is at 4 months, the augmentation. And so in this particular case, so we are preoperative and our postoperative augmentation. We placed the implant here. Now, what we did here is my friend, Dr. Semeni, and our lab master technician, Michel Magnier, gave me a stent. And this was done over 10 years ago. So on one side, I placed the implant flapless. On the other side, I raised the flap. So on here, I placed the flapless, the implant based on a guide that was given to me, directed to me by my restorative colleague. So he told me, this is where I want you to place the position based on the guide and the bone. So I placed it, and I made no incision. I placed it flapless. On the other side, I opened it up. I looked at the bone. And I placed it exactly where I wanted to place it. And so this is what we see here 3 months later. And Michel Magnier made provisional restorations for us. And this is our provisional restorations. They're screw retained provisional restorations. Now you can look at this here and you can see that the soft tissue is completely different between the two sides. On this particular patient, we have very nice, thick, attached tissue, a nice band of attached tissue, thick tissue, as you can see here when we take off the provisional. But yet on this side, we have thinner soft tissue. We have a less attached tissue. Aesthetically, the patient didn't really thought that they were both very aesthetics, but from a trained clinician eye, you can see that there's a difference between these two and that I would rather have this. So what happened? This was the side that I placed the implant according to my guide. I placed it and I placed it according to exactly where my restorative colleague wanted me to place it. And if you look here, I placed it just a little too buccal based on what the guide told me to do. The guide, and this is an illustration to you of what just a minor deviation in buccal, just slightly buccal, 0.5 millimeter of buccal position can cause tissue to look entirely different in the same patient. So you can see here, based on the guide, it led me to the wrong position, just a little bit off. So this is why I think implant dentistry is so challenging. Aesthetic implant dentistry is that that this balancing act between position, implant position, bone, and soft tissue is a very delicate balance. So let's look at how then we can manage these problems. So this was a patient that was referred to me because she has implants two implants in the anterior maxilla, and the screw had broken off, so the bridge came off. I didn't place these implants, but she was referred to me because the screw is still inside the implant. And you can see by the smile, she has a very high smile line. And so this is a patient that shows everything. So I removed the broken screw. I reattached for her the bridge. And you can see immediately that there's asymmetry in the white aesthetic due to the implant. This is not an aesthetic in somebody who has a very high smile line. And so I want you to draw your attention to this. This is not a problem of tissue recession. She has plenty of keratinized tissue, and she has plenty of bone around the implant, as you will see, crestal bone. This isn't a problem of implant position, as you can see based on this view. Now look at the CT scan. You can see buccal bone at the crest. I want to remind you that the CT scan always underestimates the amount of bone available. If you can see bone around an implant, a metal object, there's usually more bone than actually there. Because the scatter effect, metal hardening, you often see, so if you can see bone, there's bone. There's more bone than what is shown. So I asked the patient, I said, are you happy with the implants? And she says, no, I'm very unhappy. I would like to have the corrected, but my surgeon, the person who placed it, said that to remove it and to retreat this would result in significant, could result in significant bone loss and problem. So I told her, I think I can help you. And you can see there's plenty of crestal bone. It's not a problem that the implant had lost bone around the crest. This is, there's dehiscence at the apex, but there's plenty of bone at the crest, just as you can see in the scan. So what I did is so I can help her. So I removed the implant and I repositioned the implant. So I took it out and I put the implant in the new position in the same day. So you can see that all I did was I re-angulated the implant. Remember I talked about implant angulation and I talked about implant position. So I re-angulated it and I moved it back about 1.5 millimeters from its original position. And by just simply doing that, if we draw a line, you can see the tissue margin change from before and after. And all I did was reposition the implant. I did nothing else. Now I went in, I did a little bit of gingivectomy, crown lengthening on these two teeth here, just to balance out on both sides. And here's the before CT scan, and here's the after CT scan. All I did the implant is still slightly buccal, but all I did was re-angulate the implant from here to where it's more angulated, more towards the cingulum. And what it did was that you may not be able to see this on the screen that you're looking at because usually on a big theater you can see this, but the tissue thickness now is close to 3 millimeters, and by re-angulating it, I am also allowing the tissue to re-drape more coronally. So the position of the implant significantly affected the position of the gingival margin, not just thickness, but the gingival margin height. And so now when we put the final restoration, you can see there's a much more balance by just repositioning the implant. So here's our after. Now, this patient came back a few years later with chipped porcelain. This is an easy problem to fix because now by re-angulating the implants towards the cingulum, I've turned it into a screw retained restoration. Before, when the implant was too buccal, it was a cemented restoration. Now it's screw retained. All I did was I unscrewed the restoration. I sent it back to the lab and have them process the porcelain and correct this. So not only, by positioning the implant towards the cingulum, you can make it into better soft tissue thickness, better soft tissue margin, and you convert it into a screw retained restoration. It becomes an easier problem to fix. So let's talk about management now, the retreatment of some of these severe or these difficult cases. So I said that the etiology is a loss of balance between bone, tissue, and implant position. So when we look at, if the etiology is these three things, then the correction, the remedy will have to address these three things. And the first thing that I always talk about, when I talk about etiology, I always talk about bone, then I talk about the overlying tissue of the bone, then we look at the position. But in management, we go reverse, because again, we are reverse engineering the situation. The first thing you must look at is implant position, then the tissue, and then the bone. So it goes reverse order. So in considerations of management, we always look first at implant position. Then we look at defect configuration around surface texture. Of course, the presence of infection will affect how successful you are in treating some of these defects, and the surgical skill. So this is a patient that was referred to me. She has a very high smile line. And you can see from her smile line, she has a problem here with the implant that was placed. This was referred to me by a friend of mine who had placed this implant. And so what I'd like to always do is, remember said, when I show a case like this, and I often ask people, clinicians, how would you fix this? I often get three answers. One is I do a tissue graft. There's one option. A second answer, often common answer, is I do a bone graft. And a third option is I remove the implant. Those are usually the three answers. And every time, it doesn't matter what case I show, when I'm at a meeting and in a conference among specialists, very experienced clinician, and I show situations, oftentimes I get a kind of a balance of those three things. Some people, now sometimes there are very obvious where, oh, we have to remove it, but there's always a debate. I would do a tissue graft. Another person said, no, I'll do a bone graft. Another person say, no, just remove it. Before even asking the primary question, which is, what is the implant position? The implant position will affect whether you remove it and how successful your soft tissue graft will be, or how successful your bone graft will be. If your implant position is in the wrong position, soft tissue graft, bone graft is much less successful than if it is in the right position. So the first question you must always ask when faced with an ailing implant is, where is the implant position? And I think that is often lost. People jump immediately to the remedy without understanding the etiology. So what I always look is this. Between these two, whether we remove, whether we do bone graft or connective tissue graft, depends first on implant position. If it's too labial, too deep, significant bone loss or chronic infection, then this is very easily, you remove the implant. In the correct position with textured surface, a narrow non-circumferential defects or a low crest, and you have surgical experience, this is usually very amenable to GBR, bone graft. In the correct position with a polished collar, narrow, again, low crest, and surgical experience, connective tissue graft is also successful, but mainly for single implant. If you're treating multiple implants, that is a bridge in the anterior aesthetic zone, and you have a defect, soft tissue graft tends, in my experience, and we can discuss this after the lecture, is less successful along multiple implants. And we can, again, we'll discuss that afterwards. So in this particular case, I want to draw your attention to this. We have a situation where we have dehiscence of the soft tissue. You can tell that this patient has had multiple surgery this is not an infection, this is just inflammation from previous surgery. You see asymmetry between the lateral incisors. Because of previous surgery that was done by the previous clinician, you see a long lateral, significant recession here, or tissue dehiscence, and normal. Now trying to match this side to this side is extremely challenging. So the question I always ask is, should we salvage this or should we remove it? Do we do tissue graft, bone graft, or remove? So the first thing is we have to look at position. And so here you can see there's circumferential bone loss. The implant is placed a little too buccal. And so this was a very easy decision for me to remove the implant. So we removed the implant. Now, we took off the restoration. We waited for this inflammation to heal before we did surgery. There's still a dehiscence. Now, so in this problem, I have a couple of problems to solve. I need to create symmetry between these two lateral incisors, and I need to correct the soft tissue problem. The first thing I do is my incision design, as I said earlier, the open book incision. I use a site-specific vertical incision. Now, normally I would make it towards the distal, but in this case, I made it towards the mesial. I normally do not like to make this vertical incision towards the mesial because it often leaves, the incision becomes a little more obvious because it's in the front. But because I wanted to coronally reposition the tissue around lateral to create a little bit more balance with the other contralateral. So in the process of bringing this implant, we can also see we have attachment loss here. So I remove the implant. In this technique, I use the technique, my technique, the screw tent pole. I developed these screws many years ago. They're a textured surface screw. We published the first research paper on this technique. We call it the screw tent pole technique. And I came up with this name, screw tent pole, based on a concept that was introduced by Bob Marks back in 2000 and I believe 3 or 4, but it's based on essentially tenting of the soft tissue matrix to allow space for soft tissue, for bone ingrowth. And again, this was a novel concept 20 years, when that by tenting this, you allow less pressure on the bone, therefore decreasing less resorption. So we've since published a number of papers on this, and these are here, you can look these up. And so indications for using the screw tent pole is usually minor intrabony defects. So, 1 or 2 teeth defects, vertical defects, trying to correct buccal bone crest. And so here we placed the tenting screw, and you can see we corrected the crest. We were able to bring this to a high crest. Remember we talked about low crest and high crest. This allows us to bring this to now a high crest. We go from here, then we place our implant, and this is at the implant placement. We remove the screw, we place the implant. Now this was an older case. We did this probably about 15 years ago. So the implant size that I used was larger than what I would use today. This was about a 4.6 diameter back in 15 years ago. This is what we were using. Today we would never use an implant this size in the anterior aesthetic zone. Much smaller implant. You can see that there is some loss of papilla here because of the incision design. Now, this the problem, because this is a very ovoid triangular tooth. So we don't know if this is going to fill in. We know that Dennis Tarnow says that from the contact point to the crest of the bone, if this is within 5 millimeters, it fills in 98% of the time. But if this distance approaches 6 millimeter, it only fills in half the time. But if it approaches 7 millimeter, it only fills in a quarter of the time. So because of that, in hindsight now, when I look back at this case, my recommendation, a pearl that I would like to leave with you here is that in treating patients like this with teeth that are triangular, always treatment plan the adjacent tooth with a new restoration, because you have no idea whether this is going to fill in. And now you're stuck. I am stuck filling this space with this particular shape of tooth, which does not match this tooth. So that's a problem. So now we don't know. So we use a provisional. And so we put a screw retained provisional and we wait. And so this is the day of delivery. And after a few months, it fills in a little bit, but it does not fill in completely. I still have a mismatch in shape here. And this would have been easily corrected had I told the patient earlier that I'm going to do a restoration here. But the problem is I told her afterwards. So of course, when you tell patients afterwards, it becomes an excuse, versus if you tell them ahead of time, you look like a genius. So so it was restored, and I didn't like this because of the shape, and I didn't like the shade, so we removed it. We did another one. I still didn't like the shape because there's still a slight mismatch. This tooth is still slightly bigger than this tooth. So had I done that earlier, I would have solved it. But what was interesting is that when the patient came back 2 years later, you can see this papilla was here. A year later, or 6 months later, it was here. But 2 years later, it had come down significantly. So so the message that I always get from this, and I've observed this through many, many cases now, that if you wait long enough, and it's not 3 or 4 months or 6 months, sometimes it's 1 to 2 years, you will see that papilla come down quite significantly. And so now we have a little bit better symmetry. Now, we don't remove implants. We don't take it lightly when we remove implants, because removing implants, a lot of times people will say, oh, I'm just remove the implant and then I'm going to replace it. What we do know now is that when we take out implants, or implants fail and we replace them, it is not as successful as when we originally placed them. So there are 5 studies that have looked at this, that replacing a failed implant has a much lower success rate than initially placed implant. This was the study by Trukanovic in 2016, and what he found was that initial failure is about 6.4%. So about 93% of patients had initial failure. And of those 6% that they went back and did a second implant when it failed, the second implant was only 73% successful. In other words, it was not the 94%. It was much lower. And so a second attempt was reported in one study, and what they found was that if you attempt it a second time, the success rate drops to 60%. So this first initial implant placement success rate is 94%. Second one is only 73%. The first time replacement. The second time it dropped to 60%. And we recently reported a third attempt, and this was published in the Journal of Oral and Maxillofacial Surgery. And we reported this, that what happens when you attempt it a third time. So we looked at cases that had a first reimplantation, second reimplantation, and third reimplantation. And what we found in 5,000 patients was that the first reimplantation was 95%. The first 95, when the implant failed and we went back and replaced it, it dropped to 77%. And when we tried it a second time, it was 73%. And of those that failed the second time, we tried it a third time, it dropped to 50%. In other words, the success rate continued to decrease significantly after with each successive reimplantation. So we don't take it lightly that removing implants can be easily replaced. You should also keep that in mind. And also in the aesthetic zone, removing implants and replacing it results in significant issues of multiple surgery, multiple expenses, that are extremely costly and not easily available for many, many patients. So just an example to you of what patients go through in our practice or in most practices when they have anterior aesthetic implant construct that. So here we remove these 3 implants in the front here. You can see that the patient has had infection. We augment the site, and because of the infection and the purulence, the chronic infection here, grafting initially often isn't as 100% successful than after the area is cleaned and healthy. So we remove the implant, we graft it, and this is how it heals. And you can see that often these failed implants, because they create infection, that you have loss of tissue and you have significant scarring with not a lot of healthy tissue. And so we have a significant vertical defect that's often left behind when you have failing implants. And so we have now about a 10 millimeter to, more than 10 millimeter vertical defect that we have to correct here. And so you can see this, so here this is the removal to thicken the bone here. Then we come back and do our definitive surgery. In this particular case, it was a distraction, and we move the soft tissue and the bone segment down more coronally to a high crest. Remember, we started with a low crest. Now we try to bring this to a high crest in anticipation of possible of resorption. So you can see the before picture, and after you can see how much we overcorrect in anticipation of resorption and remodeling. So first stage is to remove the implant. Second phase was to bring it to a high crest. And then the third phase is to place the implant. So we go ahead and place our implants, and we use a screw tent pole to create a pontic site. And you can see, and so after the third phase, often when we do surgery, you remember before the patient had very little keratinized tissue, and when you correct a vertical defect, it often brings down unhealthy mucosa, as we see here. So we have to do a vestibuloplasty and put a free gingival graft to reconstruct the vestibule and put it attached to there. So we do a vestibuloplasty, free gingival graft, and then allow the soft tissue to heal and remodel. And this is the situation 4 years later. You can see the soft tissue after it's healed has remodeled. But you can see, what you can appreciate from this is that it took multiple surgery, very costly for the patient, and a lot of time and expense. So removing implants has lower success rate on replacement for the patients, and also very, very costly. So we don't take that lightly. So if we can keep the implants, then that would be our choice. And so the last 2 cases will show you. So if the implant is out of position, we will remove the implant and reconstruct. If the implant is in the correct position, then we'll graft with bone and soft tissue. So this was a case that I placed the implant. We took the tooth out, we placed the implant in the provisional. I didn't see the patient back for a few years, excuse me, a year later, and you can see there's significant recession and loss of keratinized tissue here. And so you can see from the natural teeth and the adjacent teeth, there's a discrepancy in gingival margin height and loss of keratinized tissue. And this is a smile line. Although the patient doesn't have a high smile line, the patient does not like to have the asymmetry of the teeth in the gingival margin. So what happened here? Why did it go from this provisional where we had balance of soft tissue and keratinized tissue to a loss of it? Well, what happened here is that I made an error here in my in a number of things. Remember, we talked about this balancing act of bone, tissue, and implant position. This implant violated all 3 things. What happened here is that this implant, restoratively, the abutment was over-contoured. So from a restorative standpoint, the provision was under-contoured, keeping the tissue margin where it should be. But when it was restored, and I didn't restore this because the patient lived in San Francisco, up north, and so he traveled down to see me. So he went back to his dentist, and after the provisional was delivered, and when the abutment was made, it was over-contoured, therefore receding the soft tissue. But what made this worse was that the position of the implant was just a hair too buccal, and the size of the was just a hair, was just a slight too large. again, because this implant was placed, I'm showing you cases that were done years ago, over 10 years ago. At this time, this implant was a 4.7 diameter. Today, we would never place an implant that size. And so it led to the atrophy of the soft tissue, loss of keratin tissue, and then thinning out of the soft tissue. And so you can see this was our problem. So how do we attempt to fix this? We have to correct this gingival margin. Now, there's two ways that we can do this. In this particular case, a connective tissue graft or a bone graft, I think would both be acceptable. Because of the dehiscence in the threads, I chose to do a bone graft first. And so using the technique, the screw tent pole technique that we developed, we placed tenting screws here. So, and we tried to correct this dehiscence, and then we put a mineralized allograft using the same incision design. We advanced the soft tissue. Again, this has been described in our paper. We call it contour graft augmentation. Slightly different than the one described by Dr. Boozer. And here we're using the abutment to contour the soft tissue. So essentially, we were the first to report on the use of bone graft to correct soft tissue problem. So this is a bone graft to correct soft tissue contour. So we're using, so unlike the contour graft that is described by Dr. Boozer, where you put autogenous bone, then layer xenograft, and then submerge the implant, I'm keeping the implant non-submerged and using a healing abutment to contour the keratinized tissue, essentially stretching this keratinized band to improve the keratinized soft tissue. And so here you see we use a healing, we put our bone graft, we place a healing abutment and contour the graft around the healing abutment, therefore stretching the keratinized tissue. And by the incision design, I can coronally reposition to a normal crest. And as you can see, the before and after of where the soft tissue was and where it is now. So we're able to go from here to where we can bring the soft tissue down, correct the keratinized band, and this is 5-6 years later, you can see. And so we published our results on this, and what we found is that we're able, you can see that before the soft tissue was about 0.5 millimeters thick. Afterwards, the procedure at 5 years, our soft tissue thickness improved to 2 millimeters, just barely above the threshold. So it's about 2.1 millimeters afterwards. And so in 14 patients that we did this on, we were able to improve the thickness of the keratinized band and the soft tissue thickness by on average about 1 millimeter. So we look here at this graph of this, here, what you see is that soft tissue thickness improved by a mean about 1.2 millimeters, and the keratinized attachment tissue also increased by about 1 millimeters, 1.2 millimeters. Essentially, that tissue parameters can be affected by only bone, by essentially placing bone, and you can see our tenting screw right there. So it's a change in the way of how we think of this balance. And so lastly, I want to share with you this young man that I placed an implant in 1998. Remember the first case I showed with you on this young man who lost 3 teeth. I took out the 3 teeth, I placed the 3 implants, and this was when after it was restored, and there is some keratinized band, but it's thin. This is and he went away, and a few years later, this is the young man that came back to my office, and he said, you know, I'm not happy with the aesthetic result of this situation. And so in 2003, remember this is about 20 years ago, and I saw this case. I didn't know how to correct this defect to be able to fix this. I looked at this and I thought, you know, this is very thin soft tissue, almost like, you know, not just you know, toilet paper, but wet toilet paper thin. In other words, if you stare at it wrong, it's going to recede. And so this is not a problem of crestal bone. The crestal bone is very healthy. There's no purulence. This is not peri-implantitis, and it's not mucositis. It's not bone loss that's resulting. It's essentially I have recession of soft tissue because I have recession of the crest, and I've lost some keratinized tissue. And so I would, you know, love to ask, and I always present this to a lot of my friends, my colleagues, friends, my periodontal friends. And I always ask him, how would you fix this? You have 3 implants right next to each other. You have loss of keratinized tissue. you have exposure of the gingival, the restorative components, and you have a reverse smile line. How would you fix this? And I always get from different folks, some people say remove the implant. Some people say bone graft. Some people say soft tissue graft. But the first thing I always say is look at the position. So is the implant in the correct position? Now here, if you draw a line across this ridge, you will see the implant is within the ridge. If it's within this ridge, it is in the correct position. So here we're okay. Remember the x-ray, the bone is perfectly healthy. There's nothing wrong with this bone. These are external hex implants. So the resorption you see is normal to the first thread. So I have two problems here. One is I have a width problem and I have a height problem. If I try to wax this up, you can see I have to bring this soft tissue down at least 3 millimeters to 4 millimeters. 1 to 2 here, about 2 millimeters here, and 3 to 4 millimeters. I have to correct the attached tissue, and I have to make the tissue thicker. So Dennis Tarnell says, do one miracle at a time. And I really believe in implant dentistry. I wholeheartedly follow those, that it is very challenging when we're trying to, in surgery, we love to try to correct everything with one shot. But rarely can we do that predictably. That when we stage things, we often find better results. And so I must correct the width first, then I'll go back and correct the height. And I want to bring the incisal ledge position more coronally to create a positive smile line. So how do we do this? Well, we have a couple of options. Am I going to remove the implant? No, because as I said already, the implant position is in the correct position. So now the question is, do I do a soft tissue graft or do I do a bone graft? Now this is a question that I'm sure will have many different answers depending on who is doing the procedure. So remember I said earlier, the 3 things in the balancing act, you have to have position, which is correct. The second thing you look at is the soft tissue, and then the third thing is the bone. Now, when I look at this tissue, this is a tissue problem that is a result of the bone, of loss of buccal crest. So should I fix this with bone or soft tissue? I always fix problems first with bone. If that bone does not correct the tissue, then I will go in with the tissue. So rather than doing tissue first, I'll do bone first. Now, this is an area of controversy because I know that there are many folks that will say, you must thicken the tissue. Because earlier I said to you that thick tissue does better than thin tissue. So shouldn't I make the tissue thicker first? Well, the problem though is that in the etiology, it is the loss of bone that receded the soft tissue. So if I can correct the bone, then perhaps I may be able to correct the tissue, just as we saw in the first case I showed you. So let's show you this. So I said earlier, my experience with connective tissue graft around multiple implants has not been good. Now, I know it's possible, but it hasn't been stable. I'll share with you a case. This was an implant that I did many years ago, and similar situation, restored. It looked okay on the day. Now, this is 5-7 years later. You see, we've lost a little bit of tissue, a millimeter here, a millimeter there. But this is a bridge, extremely challenging. So in this particular case, we decided we're going to try a connective tissue graft. So, here we use my friend Homa's technique, the Vista technique. And so, of course, I'm not an expert in this area, so I would not, try to pretend that I'm an expert in doing this technique. But I know enough to be able to do it so that at least, hopefully, I can improve it. So I put in a large piece of connective tissue. I coronally reposition it through a tunnel approach, and it looks good. 6 months, a year later, it doesn't look that bad. I was able to correct it. The problem is that over time, though, I haven't found that when I retract the lip and I pull the lip and I take a photo, because there is no attachment, There's no sharp piece fibers to implant. I often see the tissue is not stable. It pulls back up. So when I retract the tissue, when I pull it up, it often pulls away. It is better, but it's not the result that I'm happy with. And so this is often what I find. Again, we can discuss, what others have found with multiple implants. Single implant, I find it fairly easy to do, but for multiple implants, it's challenging. So here we have multiple implants. So I feel I need to correct the base first, the bone. So again, one miracle at a time, I'm just going to correct the width. So we're going to use our screw tent pole technique. The tenting screw, rough and tenting screw, allograft, correct the width first. Don't worry about the height. So here you see the before when it was dehisced, and now we cover the threads. Now we have the width. It doesn't look that great. It looks terrible. But we take pride in small little increments, little step. We have a little bit more keratinized tissue because we improve the bone. So the tissue is looking a little better. We still have a height problem. But remember, we said we're going to correct the width first, then we'll address the height. So now the next thing we do is that we know that between two implants, we have tissue height of about 3 millimeters. But between an implant and a pontic, we have a little bit better tissue height. Now, there's never been any study that has shown this. There's only an observation by Henry Salama back in 1998. He made an observation that you have more tissue around a pontic. What I have found is that it's not really the tissue. And again, there's no study on this. If you pull this paper and you look at this, this was not a study. This was just an observation, but a very astute observation. And so I've actually looked at this. We've actually measured the tissue over a pontic. And we have rarely ever found the tissue over a pontic to be as thick as what has been described as 6.5 millimeters, unless you put tissue there. But if you just go and measure the tissue around a pontic, it's about 3 millimeters. That's the biologic width. You rarely see it that 6 millimeters. So I think that this number is not a real number. That is not 6.5. In fact, I would say that if you took your CT scan and measure, you will find that what I'm telling you is true. That is about 3 millimeters. It's that over time, remember the high crest, the bone drops down. So how do we affect it? Well, we create a pontic. So I remove this. Now back then, I was looking at this thinking, oh, if I remove the implant and I put bone and I create a pontic, I'm going to get more tissue. And that was my initial thinking. Again, this is back in 2000 and, in the early 2000s. So I removed this implant. I extended my screw, the 2 screw tent pole. I put my allograft, put my membrane. So this is a technique that we use even for vertical augmentation. We've been using this technique and quite successfully for this. So we just put the screw, and this is what it looks like. There's some exposure here, which I expect from where the implant came out, which I leave exposed. I purposely leave this exposed. It fills in with keratinized tissue because it's surrounded by keratinocytes. And this is what from before to after. This took 12 months. Now, I ask you, how is it 2 things happen? I went from a low crest to a high crest. I went from little keratinized tissue to a lot of keratinized tissue. Yet I did no tissue work. There was no connective tissue graft. There was no free gingival graft. But yet we improved this. How is it that we went to the high crest? It's through incision design, graft placement, and localizing of the graft. And was it tissue? Is this tissue actually 6.5 millimeters? Actually, it isn't. It's actually the pontic site. We create a high crest. So now we use our provisional restoration. If you look at our x-rays, you see we've created a high crest. It's the bone that created the soft tissue. It's the bone. If you look at the tissue at the pontic, you will measure it about 3 millimeters. And so going back to my study that showed that if you make the bone thick, you will have very thick soft tissue. And so we created the bone, and then we put in provisional restorations, final restoration, keratinized tissue. The pontic, the bone you see is getting harder and more mineralized. You can see it more now on the x-ray. So high crest, low crest to high crest, no tissue, loss of keratinized tissue to attached tissue. So you can see, now is this result stable? This was 2004. This is now, I've seen this patient now for almost every 6 months I see this patient. 2019, pre-pandemic was when I last saw the patient. Is it stable? I call this concept bone-driven tissue transformation. Just want to introduce a new concept to many of you that maybe have not seen this, is that I'm transforming tissue parameter using the concept of balancing the bone. So is it stable? Well, this was a CT scan we took. Now you can see, again, these are external hex implant done years ago. The bone is about 2 millimeters thick and the soft tissue is close to 3 millimeters thick. Remember, the soft tissue here was non-existent and it was about 0.5 millimeters thick. And now it's close to 3 millimeters in thickness. So with that, I want to conclude the lecture and I want to leave you with a few take-home pearls. And the take-home pearls, the first one is this, is that aesthetic failures should be acknowledged as part of the overall treatment plan. And in other words, it is part of the overall risk. Aesthetic failures can have a devastating effect on treatment outcome. Remember the first study that I showed you where 24% of single implants can have aesthetic failure done by experts. Now that means that 24%, if you have to retreat in your office, is a very challenging number that is essentially not a practice builder. And replacement treatment is not as successful. Remember the numbers I showed you that are from our study, that the first placement in 5,000 patients, we had a 95% initial success. Of the 5% that had the failure, when we went back to place it, the success dropped to 73% or 77%. When we did it a second time, it was 73%. When we did it a third time, it was 50%. So in other words, each successful placement of a failed implant results in significantly lower success rate. So what should you take away from that is that don't take risk with your initial treatment. All too often, I see people especially on social media, show a case. Look what I did on this case. Look, there's no bone. I did the implant. Simultaneously, I did my bone graft. Look how great it looks. And I always think that is a great result. But what if it failed? What if that case had failed? Medicine is not an exact science, and we don't have 100% success. And that it is the road, once you commit a patient to failure, now you have a slippery slope of continuous failure. So replacement treatment is not as successful as initial treatment. So never take risk on your patients. And that you should be prepared to address the consequences of implant failure because they are real and they are common. And that the balance between this, going back to this, that it goes to this, the reason why implant treatment is hard to do aesthetically is that it results in a very delicate balance between these three things. You must keep the balance of bone, of soft tissue, and implant position. And that deviation in any one of these can affect the other. And that the last message is that, that I leave you with is that life isn't a bowl of cherries or peaches. It's not always, roses and petals. That is more like a jar of jalapenos. What you do today may burn you tomorrow. So be careful what we do today and follow the cases for 5, 10, 20 years. And it's the more you practice, and this is the reason why the more you practice, the more conservative you become. It's because those 5-year cases, those 10-year cases, those 20-year cases that come back and burn you, that you learn from. So with that, I'm sorry I went over, but I hope to leave you with this message that, I hope that it helps many of you.
Thank you so much, Bach. Truly enjoyed every second of your presentation, and it was full of important points that truly we can say that just by watching this webinar or with this lecture, we can easily say that, as you exactly said, first of all, as we practice more and more, we become more conservative in our treatment because we know more and we know how we can make our outcome predictable with uh, interventions, and keep it simple for our patient, but predictable at the same time. So, first of all, again, thank you so much for this beautiful presentation. And I have some questions regarding your beautiful cases, and some of them are really my own questions. The first one is regarding the case that you showed the implant positioning was a problem, and you decided to remove the implants and redo the case at the same time. So it was in the anterior zone, if I remember right, and the implant in the lateral or in the canine area
Yes.
on the left part of the patient. You placed the implant, brought the platform of the implant to the cingulum, but the apex of the implant was toward the buccal. So my first question is this: why you didn't decide to bring the implant bodily to the palatal instead of tilting it? And does that tilting implant, the apex of the implant to the buccal, can cause future fenestration or any problem in the future in the apical part, or no?
That's a great observation. So there's, so essentially this is an immediate placement concept. So very similar to an extraction site placement. So I felt that the initial implants were very buccal, so that for me to correct this, all I needed to place more palatal. But the problem is that on these ridges, it is not just like in an immediate implant placement. What I see often is that you have a ridge where the root is almost fenestrated, right? In a natural tooth, oftentimes the root is almost fenestrated. And because I would like to achieve a screw retain restoration, that's one thing, is that I like everything to be retrievable for my prosthodontist, number one. Number two, the angulation improves the tissue, those parameters. I have rarely ever found that implant fenestration causes a problem. It's implant fenestration at the crest that is close to the surface, close to the oral environment, and bacteria can cause problem. But deep inside rarely causes a problem, number one. Number two, when I get fenestration, I often graft it. So I'll layer some bone over those fenestrations. So I'll usually try to correct that. So in the postoperative CT scan, if you see it, you see that it's completely covered. So those fenestrations we usually covered. So usually there isn't any fenestration if you graft it. But if there is fenestration, I'm not really that concerned about it as I am with fenestration at the crest.
Yeah. So,
and
yeah, go ahead. I wanted to know also about the direction. Do you prefer to place the platform in the cingulum and the apex toward the buccal, or you prefer to go completely bodily to the palatal? I mean, I'm asking this question from the prosthetic point of view. Which one is easier to restore?
It's easier to restore to angle it than to bodily move it. If you bodily move the implant, you essentially create a cantilever, a buccal cantilever effect. So for every millimeter you move towards the palate, you're increasing the unnatural torque, or you're creating more of a cantilever effect on the restoration. So I try to do a combination of both. I don't, the cantilever force I'm not that concerned about, because in the anterior there's a little bit less force. What I am concerned about, which you bring up, is a very good point, is that the more I bring it palatal, the more prosthetic ledge I create. So we know now that the angulation of the prosthesis can cause a biological or hard to clean and can create biological issues. So yes, we want to soften this. this ledge. We don't want to create a right 90-degree angle if we can avoid it. So by combining both and placing the, so for every millimeter palatal delete that I place it, I actually place it 1 millimeter deeper. So the implant is then deeper to lessen to lessen this off balance, to soften this curve, to create a little bit more of a profile, to not impinge with my restoration. And then what I also find is that, again, by placing deeper with platform implant, you sometimes can graft slightly equal to the platform or even slightly coronal to the platform. As I show in those CTs, you look at it afterwards, you see a ledge of bone that is right at the crest of the platform, or at the platform, or slightly coronal to it, the further you go out. And it allows me to then soften the curvature. So yeah, I like to angle it if I can, and that's usually how I place my implants in the for immediate implants. I think Joe Kahn's group published a paper that showed on CT cross section that I think at about 70% of implants are not able to place screw retain. That because of the trajectory of the ridge, the ridge is such that engaging bone forces us to place it through the buccal, creating a labial inclination. What I have recently, and I know that study, because one of the, it's a great study, and one of the student that participated in that study also spent some time at my office, a few months in my office, to learn some of the techniques. And so I had a discussion with him. I said, well, show me how you cut the section. And so the problem that I find is that if you only look at one dimension, when you take a 3D scan, you cut it into a one-dimensional, two-dimensional view, you often get the impression that you must place it this way because that's where the bone is. But you have to remember that there's three-dimensional bone. So often I can still angle it towards the cingulum, even though it looks like the engaging bone is here, but I can still, because I'm engaging it only the palatal half of the implant. So on scan, it may look like there's you can't engage it, but you can actually engage and make implant screw retain by engaging only the half of the implant. The diameter, not the diameter, the circumferential half of the palate.
And I think maybe also co-axis designs also help us through such situations, and by placing this way, but we can correct the platform to the area that we really wanted to place the implant. And what's your idea about them?
Oh, I think that's a great idea. Stephen Chu, yeah, he a few, this, I remember I talked to Steve and he showed me that concept, and seen a lot of his material on that. I've spoke with the folks at Southern Implant, excuse me, not a Southern Implant, what's the name of the group?
Actually,
I like that concept.
It's by the Inverta, the one by Steve Chu, Inverta Design.
Inverta
by Southern, yeah.
Yeah, by Steve Chu. Yeah, I'm sorry. Yeah, that's the comment. I didn't want to, the correction. But yeah, I actually think that's a really nice concept, a great concept of actually, it brings into the concept of what I'm saying about angulating the implant and bringing, creating a gap and creating more bone and soft tissue. And actually, I think that's a marvelous concept that he came up. In fact, he often cites our paper in his work on that implant. Yeah, no, I think it's great. I've seen by a lot of my colleagues, and I'd love to get my hands to be a part of that whole group doing that. Barry Levin's showing some great cases, how you make the platform smaller and you can change the angulation. I think that's a wonderful idea.
Exactly. And Bach, have
you tried it?
Actually, I've tried coaxial implants, but not the Inverta yet, because we don't have Inverta now in Iran, but hopefully soon I would like to try it. And regarding one of the cases that you also present, and you showed the papilla growth over time between two central incisors. And as you said, sometimes we need to take time and we see that things getting better. But my question is this: if we want to predict, or if we want to increase the chance for the soft tissue to grow, I mean, specifically the papilla, should we go with the under contour restoration, or should we go with the exact profile that we want on the day of delivery? And is there any difference regarding what we can expect in the future or no?
That's a really, really, really great question, very insightful question. And this is a question that the topic that has a lot of controversy. If you ask this question to a group of experts, 5 experts, you'll get 10 different opinions. Mm-hmm. Some people would say, in fact, at the American Academy of Aesthetic Dentistry 3 years ago, we had a counterpoint just on that topic, with a group saying always under contour, another group always saying to create normal contour. And so I think that it goes back to the, medicine is not black and white. There is not one answer that is correct. The answer to that question is it depends. And it depends on 3 things. How much papilla comes down, of course, depends on the anatomic bone supporting it. So that, of course. But how much it comes down depends on how much surgery you have done on it. So this is often, so if I ask, how long do you put the provisional on to groom the soft tissue? I get all kinds of answers. Yeah. Some people say, oh, I put it on for 3 months. Some people say for 4 months. Some people say 6 months, right? But I have seen soft tissue change after 2 to 3 years, significantly, from 1 to 2 to 3 years. And we didn't have time in this lecture, but I've given this topic in many other lectures where I've shown soft tissue with a provisional that it didn't take 6 months or 4 months. It took 2 years. And I've shown significant documentation changes in these, and maybe one of these, other lectures that you can see. Why did we see this? Because then I in the initial phase, I show the clinician there's 2 implants in Pontic, but the Pontic is short, it's shy. Now, if you restore it, you have to have pink porcelain. But I show in the end, we didn't use any pink porcelain. What was the difference? Well, because we waited, and we waited almost 2 years. Why did we wait long? Because so how much it comes down depends on how much surgery has done on it. Remember, collagen reorganization occurs over time. So an analogy would be if you fell down and had a scar on your face, and I sew your face together, now you have a scar. You notice when you have a scar somewhere in your skin, it always leaves a little bump, right? That's collagen. When it first reconnects, it forms almost like a ball of yarn. And so this ball of yarn is this little bump. And over time, the collagen has to reorganize so that it slowly becomes parallel. And as it parallels, it softens and it lays down. And so that's why the plastic surgeon never does a scar revision right away. If you have a scar, you come back to the plastic surgeon and say, I want you to resect the scar. He always says, wait. How long do they wait? About 10 to 12 months. Why? They want the collagen to reorganize, to soften, to lay flat. And so that's why they tell you massage it, get the collagen reorganized. This is exactly the same situation when we do surgery, these cases. So that lays, I didn't talk really about what happened there, where the tissue came down. That took 12 months. Now, why did it come down? Well, he only had 2 surgeries. I have cases where we have the initial removal of implant, grafting, implant, and then the implant placement with more grafting, and then soft tissue grafting. 4 surgery over a 1.5 year period. Now you have significant collagen contraction. If you wait 3 or 4 months, it's nothing. It's not going to come down in 3 or 4 months. It's going to come down in 1 to 2 years. So when I talk about vertical augmentation, and because we never have time to talk about the little details. What people don't see is that I keep them in the provisional for a long time, and I play with the provisional. So how much comes down depends on how much surgery, how much, where the anatomical bone is located, and it depends on the soft tissue profile of the patient. Some patients will make more, have the ability, and some actually will shrink. So how much you weight really depends, how much surgery, how much bone supports it. If you have a lot of bone and you have really thin tissue, that tissue will mature and will come, as you know, right? Just like over an extraction site. You graft it, it's real thin, then slowly thicken.
Yeah, but should we have a space for that tissue to grow or no? Because if we don't provide that space,
yes,
grow.
Yeah, so absolutely. So going back to so during the first 6 months, okay, depending on how much surgery was done, I wait. By under contouring. So I under contour or nothing touching it. So that last case I show you on that young man that I waited 12 months, there was nothing touching it. There was a space. And that's the most challenging part of implant dentistry, aesthetic implant dentistry, is that most patients won't accept that. If you leave a black hole, they're going to stare at the black hole. And what my challenge in working in the United States is that, as a specialist, is that I work with restorative dentists. When I remove the space, the patient goes back to the dentist, complains about the black hole, the dentist puts it back, and it chokes off the tissue. And so, yes, you're absolutely right. Those cases, like the first case I show you, where I told a high crest or a normal crest, we want a high crest. The only way to achieve the high crest is time and bone. Leave it alone and leave a space. It will come down. But the problem is that most people don't like to leave a space. So what I usually do is I do a modified ridge lap. So I do a modified, I reduce everything from the palate, very little touching. And I reduce just enough that at least maybe a 1/4 millimeter. Then I see the patient every 2 months.
Yeah.
And the other thing is that I don't draw the patient's attention to it. If there's one pearl I can leave anybody is that on provisional, is that don't open up the papilla embrasure too much. Don't get lazy, open a big hole, and then re-screw it in and tell the patient, oh, we're waiting for that to fill in. Because you're setting yourself up for failure.
Yeah.
That patient is going to go home and stare in the mirror. And if that doesn't fill in all the way, they're going to say something is wrong. Then when you put your crown on, they're going to know. So what I do is I just open just a 1/4 millimeter. And I don't tell them anything. I just say we are just allowing the tissue to mature. But I never tell them we're trying to wait for that to fill in.
Yeah.
Because studies have shown that patients only know white. More than they know pink.
Yeah.
They know the white. If the white is symmetrical, the pink is less important in terms of the papilla height. It's important, but if the white is somewhat symmetrical on both sides, then they'll be accepting. So that's a very good point. So that black hole, the black space underneath there, you have to leave. It's so critical. And you have to leave it depending on how much surgery was done. And that's a whole nother topic in itself, on how much time and the little details of creating that is a whole nother interesting topic.
I know. And I know, Bach, because your topic was so interesting, and we can, as you said, we can talk about it for hours and hours, but our time is limited. So I want to just have the final question, because I really like the concept that you brought at your final case with that tissue transformation. So the thing that I concluded, I want to know if it's right. If we go with the contour augmentation with bone grafting techniques, can we say that we can change the nature of the tissue covering the area? Because the case that you presented with three failed, I mean, like receded implants, and you removed the middle implant to make sure that you can increase and enhance the soft tissue there for better aesthetic outcome. When I saw your case in 12 months follow-up, what was interesting was that, first of all, you didn't do any soft tissue grafting, and with only contour augmentation, you achieved exactly the way that you wanted things to happen. And secondly, when I compared the initial case with the post-op result in 12 months, it seems that the tissue has changed from non-keratinized to keratinized attached gingiva. So, and as you said, tissue transformation. So can we say that the contour augmentation can change the nature of the tissue over time or no?
That's a really, really, very, very good question, and I love that. So the so we published this paper, so you can see it in the and I had actually listed 4 reasons why this happened, because this was done many years ago, and I remember it changed the whole way that I think about this, because as you know, you're a periodontist, I'm an oral surgeon, and in the beginning, I think that many people, as I said in the beginning of the lecture, many people say the bone sets the tone and the tissue is the issue, almost implying that they are 2 distinct entities. You must fix bone, then you must fix tissue. What I've learned from these cases very early on now and observed, and I'm continuously a student of this, is that the bone and the tissue is so interrelated in so many ways that we didn't think of before. Traditionally, I was trained, you fix the bone, then go and fix the tissue, and then go and put the crown, provisional, and all that. But what I have observed over time is that I was able to correct a lot of tissue parameters if I was able to correct the bone. Now, that does not mean if you put the bone, all of a sudden you have better keratinized tissue. That is not the case. So why did it happen that I have better keratinized tissue when I had very little to begin with? So there's 4 things that I see that happened here. The first is that why did the tissue become more fibrotic and keratinized? Well, from some of our studies, I showed you, we make the bone at the crest thick, then the soft tissue is usually thick. That's always the case. I've rarely ever found in the anterior, now not in the posterior, I have to specify in the anterior, I have never found, and when I take a CT, taking CT retracted to receive the relationship for many years. And so what we always see, if the bone is thick, you will not see thin tissue in the anterior zone. You might see that in the posterior, but try it. In fact, I always tell people in the audience, you have my email there. If you take a CT scan, or if you measure, you have really thick crestal bone and the tissue is like paper thin, send it to me. You'll never see it. So what we found is that make the bone crest thick, the corresponding soft tissue right over it is going to be really thick. So that's the first thing. That's the first rationale. Make the bone thick, the tissue becomes thick. So fix the crest. Second thing, in the process of putting the bone and the contour, you are actually you are contouring that thick tissue now around the new provisional restoration. When we put the bone there, we have to score, and in the process of scoring, you're creating scar tissue. Yeah. You're creating and then you're putting a foreign body. You're putting this biomaterial that then encapsulates into this area that you scored, and then and it creates scar tissue, so more fibrotic tissue. And then the third thing that I find is that it's that collagen. I'm putting a membrane over it. So that membrane is essentially also a biomaterial or an allograft or a, what have you, that's thickening the soft tissue. And so that essentially creates a site. And then the third thing is this, and this is, you're very astute in observing this. I use a concept that we are in the process of publishing. In fact, this study we did, it's a multi-center control study, split mouth control study. We're using the concept of exposed healing. So I leave the area purposely exposed. So just like I showed you in the first guy, I just kind of alluded to it. I don't want to get too much into it because of time in the beginning in these lectures, but I leave these areas purposely exposed and I reposition the surrounding tissue with keratinized tissue. So I just kind of pointed it out, and as you see how it's exposed right there, that's how my secret. So I call that all. So in fact, we did this study in collaboration, myself with one of the doctors who since graduated from UCSF, but was in the perio program there. This is part of her master's thesis. So it was a split mouth study. On one side, we did non-flap socket preservation. On the other side, we raised the flap and closed it primarily. And the area that was exposed with the graft material, then we went back and we did micro CT, we did histomorphometric, and we looked at tissue parameters. And what's interesting is that, and this has been shown by Barone and a couple other studies, that by leaving the area exposed, surrounded by keratinocytes, you get more keratinized tissue. Yeah. So a lot of those cases where I am leaving it, so I'm using that concept to gain more tissue also. So those are the 4 things of how I was able to do that, to gain that keratinized tissue.
That was truly interesting. As I said, Bach, we can talk about it hours and hours, and I truly have to say I enjoyed every second talking about it with you, and really enjoyed the beautiful presentation and a comprehensive one. And I want to say that I'm really looking forward to welcome you soon in my country, in Iran. And as you know, I run the Symposium of Complications in Implant Dentistry, and I think it's a great platform to have you as one of the leaders in this field to give us the pleasure to joining us. So hopefully very soon after this pandemic situation become under control. Once again, thank you for accepting the invitation. It was a pleasure. I'm pretty sure all the audience have enjoyed, and hats off, my friend. Thank you.
Thank you, Omid. I really, again, I appreciate I'm really honored to be able to present. I would love to come visit Iran. One of my, it would be the highlight of any travel trip for me to come visit you and visit your country with so much history and rich culture. And again, I really want to thank you, and I want to congratulate you on a job well done. I, continue to do all the good work that you're doing, and I hope to see everybody soon in person. We can all enjoy FaceTime and some dinner and drink together. So thank you again, Omid. I appreciate everything.
Thank you so much, my friend. Bye-bye. We'll be in touch. Thank you.